Hi, everyone. Welcome to this session this afternoon. Welcome to today's educational session, Navigating My Treatment Journey for HER2 positive gastric or esophageal cancer. This patient town hall is provided by Prime Education in partnership with Novelia, and this activity is supported by educational grants from AstraZeneca and Daiichi Sankyo. So we're going to go through some housekeeping slides before we introduce the program itself. Am I able to share my screen, or are you guys sharing your screen? Perfect, thank you. Okay, just want to quickly introduce myself. My name is Mahati Vajala. I am a stomach cancer survivor and advocate from Hope for Stomach Cancer. In 2022, I was diagnosed with stage 2B stomach cancer, signet ring cell gastric adenocarcinoma. And since then, I have gone through surgery, chemotherapy, and immunotherapy. After I had gone through chemotherapy, I wanted to start advocacy work because when I was diagnosed at 31, I was very overwhelmed, felt completely lost, didn't even know stomach cancer still existed, especially in people my age, and wanted to start giving back to the community and helping them navigate this journey. Our expert faculty here presenting today's webinar is Dr. Jaffer Arjani. Dr. Arjani is a GI medical oncologist focusing on gastric and gastroesophageal cancers. He has a lab and a large clinical practice, and he's a professor of medicine with the Department of Gastrointestinal Medical Oncology at the University of Texas MD Anderson Cancer Center in Houston, Texas. Next slide, please. This slide indicates how Prime, it's an accredited medical education company, reviews all disclosures of relevant financial relationships and resolves any potential conflicts of interest as part of its educational planning process. Next slide. This slide presents all the disclosures that our faculty member may have with any financial relationships from our faculty, and it resolves any potential conflicts of interest as part of Prime's educational planning process. Okay, this is an important slide. It just kind of tells you how to navigate Zoom. It highlights the most important Zoom features, such as muting and unmuting yourselves, as well as your video options. So feel free to turn on your videos if you want to. The chat box is a great option for you for discussion. So we're going to go through, we have some questions for discussion. So please feel free to use the chat box. You can also change your name on Zoom. Sorry, can you go back to changing your name? You can also change your name on Zoom. So there is a where we can show you how to change your name for privacy. If you'd like to do that, please let us know and we can go back to this slide. Okay. All right, next slide, please. So please note that the first part of the program will be stomach cancer education led by Dr. Arjani. Then during the last 15 minutes, we will have Novelia introduce a new platform that they've developed for patients. So please make sure to stay on for the entire session so you can hear more information about this enrollment opportunity. The session is designed to be interactive, so please use the chat box to submit any questions or comments as we're going through our session. Poll questions will also pop up on your screen throughout the presentation, and we encourage your participation for these questions. You will be able to see the polling results once the poll has ended. And at this time, I'd like to hand off to Dr. Arjani to move forward with the presentation.
Yeah, thank you, Mahati. I feel very privileged to be part of this because so many patients are involved. So I practice at a large cancer center, and I treat patients with gastric and esophageal cancers. And I'm very happy to participate in this. We will be focusing on HER2 positive tumors today. So I know that on the left side it says you are not alone, but that's really not enough, because I know a lot of stories about diagnosis of gastric cancer, and it is almost never good. It's a big problem in this country, even though Federal government thinks this is a rare cancer. You can see the numbers, 26 to 27,000 gastric cancers and 22,000 esophageal cancer. Total can be up to 50,000 newly diagnosed cases every year. So that's a huge problem, and I think we need to work harder to make things better for our patients. So it can present in multiple stages. Early stage will be like a younger cancer that has not had chance to penetrate the stomach or esophagus wall. This is very uncommon in North America because we really don't have any method of early detection right now. So patients are diagnosed when they are symptomatic, or incidentally they're diagnosed because they're having another procedure, and then they end up with a diagnosis of esophagus or gastric cancer. In that case, cancer can be at earlier stage, but majority of patients, unfortunately, when they're diagnosed, is already quite advanced. So since we're focusing on HER2, it's a protein that uh, is on the surface of cancer cells. Then it also passes through the cell membrane or the wall of the cancer cell. And then it has a tail inside the cancer cell. And essentially, when this is a kind of protein that can help cancer cell multiply and migrate, and that's what cancer cells need to do in order to survive. So this is a very good protein that can help the cancer cells, and almost 15% of uh, these type of tumors will rely on HER2. There are, of course, many other markers, and we will hopefully get into that. So other platform that has emerged in the last 20 years is what is called multidisciplinary conference. So, for example, in my institution, it is not written anywhere, but we don't really expect one doctor to make all the decisions. So because if they make a mistake, then the patient and the family catches the mistake. So what we normally try to do is bring especially curable conditions in the multidisciplinary conference and get advice from all the colleagues with different expertise. The one that is missing here is the radiologist. But usually there are like 15, 20 doctors, and you present patient's medical history to everybody. Radiologists will review it, pathologists will review, and then there's a discussion, and then there's a consensus. This type of decision making is so much better than one doctor making the decision. So I think you can also ask your primary oncologist whether there is a chance to get it reviewed by other doctors in a conference. So as I mentioned, unfortunately, most of the patients have metastatic cancer already. And that's because we have so much room in our body that these cancers can continue to grow and you wouldn't know, or you will have this non-specific annoying symptoms that are not serious enough that you go to the doctor. So when you go to the doctor, you already got a lot of symptoms. And cancer cells like to multiply and migrate out because that is a survival tactic. So cancer in the body of the patient is really trying to survive. Okay. So there are two goals. I mean, which is not listed here is what we want, which is the cure. And fortunately, it is happening in some patients, even though they can start with stage 4. Some of them are cured today, which is wonderful. but not enough patients. So for majority of the patients with stage 4 cancer, one goal is to increase their survival and in a meaningful way. And I can tell you, no matter how much increase there is, it is not going to be sufficient. So if we say to a patient and family that you're going to live 6 months longer, well, that's not going to be enough. So I think, as I said, we need to do a lot more work. And on the right side, you can see one thing we don't want is the cancer to grow because it causes a lot of symptoms. The growth of the cancer causes symptoms and can shorten survival. So at this point, Mahati, if you will moderate this section.
Yeah. What questions do you have about gastric and esophageal cancer diagnosis and biomarkers? Please use the chat to put any questions in. And Dr. Ajani, I have a question. How long does it usually take to get results from biomarker testing? And how does the biomarker test work? Can you give us an overview?
Wonderful, yes. So biomarkers are the drivers of the cancer cells, and it can take it. So the number of days it takes can vary from institution to institution. At my institution, it can take almost 6, 7 working days. Even though our pathology department may have the cancer tissue of a patient already, it does take them time because they do a lot of work and quality control, and they won't release the results just like that. So this is another, opportunity to make a mistake. So everybody wants to be very cautious. And then now there are multiple biomarkers. So, but the tissue is very small. So it's an ongoing challenge. And we hope that we will have a blood test to figure out these biomarkers.
Okay, thank you. Can you explain the difference between an established biomarkers and emerging biomarkers? And can you
Yes.
talk a little bit about the biomarkers that already exist? You did slightly touch on that, but the biomarkers that exist and then the difference between established versus emerging.
Yes. Fortunately, the list of biomarkers that we can exploit is continues to increase. So that is really good. So, many years ago, we were treating every patient the same way. Everybody got chemotherapy. We didn't know all these biomarkers and we didn't pay any attention to genetic makeup of the tumor. But that has completely changed. So the next patient, newly diagnosed patient, I want to know what biomarkers are being used by that patient's cancer. So the established ones were HER2, PD-L1, microsatellite status, and more recently, some institutions are checking EBV, which is a virus, the Epstein-Barr virus can cause stomach cancer. And as of last week, we have a new candidate, which is Claudine 18.2. So we have 4 or 5 right now, but we hope we will have almost 10. So this way we can very accurately treat our patient, not treat patients without the knowledge of biomarkers.
No, that's excellent. I had the PD-L1 marker and I nivolumab because of my PD-L1 marker. There are quite a few questions in the chat, so I want to go through some of them. How common is it for various institutions to get different HER2 results from the same tissue sample?
That's a very good question because all biomarkers we discuss, they're what we call heterogeneous. That means on the left side of the tissue, including where there is cancer, the biomarker can be negative. On the right side, it will be positive. Sometimes the biomarker is negative, but you treat the patient with something else, that biomarker becomes positive. PD-L1 is a very good example. So it's an ongoing challenge for us in the clinic because right now the guidelines say you test only once and in one biopsy, um, and you don't need to necessarily test the same biomarker again during patient's journey. But I think all of this is going to change as we move forward and we gather more knowledge.
Right. And on that note, if a patient is not HER2 positive at the time of initial testing, can they become HER2 positive later?
So this is not very well known, but you may have missed it the first time because it was positive where you didn't sample. So this issue is being addressed by American College of Pathologists right now.
Oh, wow. Okay, that's good to know. There's some questions here about diagnosis and like testing for biomarkers between Caris and Signatera. So one of the questions is, why can a Signatera test show some markers are positive and a Caris test can show others? Many patients will not know what to do with these various tests or what the results actually even mean.
Yeah, so I think it's a decision, individual decision of the company. And Caris decided that they will check the biomarkers and the genetic alterations. So those are completely two
Okay.
different things. And Signatera just checks genetic alteration. Signatera, there is an issue. They give you a number, especially when we do the what is called liquid biopsy.
Mhm.
And I don't particularly find that useful because there's nothing you can do with the number. We want the alterations which can reflect the drivers, and we can treat that.
Okay. What are the most promising biomarkers for early detection and diagnosis of gastric and esophageal cancers, and how do they compare to existing methods, such as endoscopy and biopsy?
Right. So this is a very important question. We don't have a group of biomarkers for early detection yet. And by that, you might mean, doing a blood test and looking for certain changes. This is being worked on by many companies. We don't have any yet.
Okay. There are some questions in the chat of Claudin 18.2 and being HER2 positive, but I think we can get to that during the next discussion because I know you're going to talk a little bit more about HER2 positive. So we'll bring those questions in for the next discussion. Thank you, everyone.
Okay, thank you. So let's get into some of the available treatments. Not too long ago, we had just chemotherapy for HER2 positive tumor patients, but now we have more and more treatments. So we have this trastuzumab, which is also called Herceptin. That's been around for gastric cancer, esophageal cancer patients for maybe 13 years. And then more recently, we have trastuzumab combined with chemotherapy, and that is called ADC, like it says in the green box, antigen or antibody drug conjugate. And then we have immunotherapy that we can use, particularly pembrolizumab. And one thing to kind of remember about HER2 is a very unique target. And you can target it over and over again, which is kind of nice because you might know that in breast cancer, you can target HER2 4, 5, 6 times. And I'm hoping that we will be able to do that for gastric and esophageal patients. So in other words, we can keep treating patients for a very long time and continue to target HER2. So when the patients are first diagnosed with metastatic HER2 positive cancer, then we treat them with what is called the first line treatment. And that can be chemotherapy, trastuzumab, plus minus immunotherapy, depending on the PD-L1 status. And second line, right now we have only one drug, which is it is called TDXD or Enhertu, and this is antibody drug conjugate. But I suspect there will be many more as we move forward, which will be great. So selecting the right treatment, we will get into shared decisions later on, but it really depends on what biomarkers are being presented. And of course, we have to take into consideration multiple other factors, like patient's general condition, the type of side effects that can occur, and the goals of the treatment, and also the quality of life, etc., that we will discuss later on. So I think most of the patients are very well informed nowadays because of the access to medical information online, and also the family and the friends are helping. So I think it is really important to engage your provider with some information that you already have learned. So, but there are still issues like particularly quality of lives. So if we give you one systemic chemotherapy and antibody and you get very ill, I mean, then you want to say to yourself, I don't want to live like that. So that needs to be discussed with your doctor so they can make adjustments, or you can sometimes say, I want totally different treatment. So this kind of interchange is very necessary nowadays. We didn't do a lot of that before, but now I think you can have informed conversation with your provider. And there are many questions, and a lot of times, newly diagnosed patients and their family, when they're in front of a provider, they are overwhelmed. First of all, they are highly stressed because they got the diagnosis of cancer. Second thing would be there's so much information is being given to them. It's very hard to digest. And sometimes what we have to do, and we should do this, um, knowingly that this is how we need to navigate patient's journey, is to repeat the answers and make sure that you can't say, I already explained that to you. You have to re-explain everything carefully. And sometimes the caregiver can learn one aspect of the treatment, like a management of side effect, and patient can learn one thing because patient cannot digest everything. So there are always many questions, but please repeat them and get your answer till you understand the answer clearly. Okay, so another very important thing is the clinical trial. And as all of you know, clinical trials are using or developing very promising drugs. So now the drugs that are coming into the clinic for development, they are much better drugs than we used to have. So, but when they come into the clinic for the first time, we don't really know how much to give to patients, how often to give, what are going to be the toxicities, how they metabolize the drug, what are the long-term side effects. But clinical trials, a lot of them have very, very promising drugs. So I encourage you to keep an open mind in enrolling in a clinical trial, but certainly you want to collect a lot of information. So common questions about clinical trial that I get asked is, am I going to get a placebo? And we are almost stopping to do what we call inactive control. In other words, I don't want to give one of my patients something that doesn't have treatment for their cancer. We did that long time ago, but we have almost stopped that. There are still placebo-controlled trials, but they are accompanied with treatment. So in other words, there can be some chemotherapy and a placebo versus chemotherapy and the drug, because the FDA requires a design like that, but everybody gets treated. And the question of guinea pig, etc., that I know it comes to the mind, but we we try to explain everything to the patients, and patients are always given a choice. So it's not like we are saying to you there is no other choice but to go on this trial and you will be in the placebo group, etc. That you don't want to hear from anybody. And clinical trials are not for everyone. There is a long checklist, unfortunately, and every check has to be uh, in the positive direction for you to qualify for the clinical trial. And you normally don't have to pay for the clinical trial components, such as non-standard tests or the clinical trial drug. That you don't have to pay. It's against the FDA rules if any institution asks you to pay for non-standard test, for example. And your participation will certainly make a difference. What we want to do is you enroll a patient on a clinical trial and hope that that patient, that particular patient, will benefit from the treatment. And that information will help other patients for sure. Okay, Mahati, so please moderate this
Sure.
session.
Thank you, Dr. Ajani. So, to our audience, what questions do you have about treatments for HER2 positive gastric and esophageal cancers and enrolling in clinical trials? And then also, what tips do you have for talking with your doctor about treatment options? I do have to say, I really resonate with some of your slides that you presented in this section. With the questions to ask your doctor regarding your treatment options. I was very overwhelmed when I was first diagnosed, and towards the end of my treatment, I was joking around and saying that my husband had basically become a doctor because of how much he had read about gastric cancer treatment options, questions I needed to ask my oncologist. And you're right. Every single oncologist that I've encountered have been so patient and very, very careful with their responses. I want to ask, before we get into some of the questions in the chat, I want to ask, what are some benefits? Can you talk about some benefits and risks of participating in clinical trials for patients?
Yes, that's a very good. There is actually a section that is now required in the informed consent that says why would you not want to participate? And the FDA did that because to avoid coercion, we don't want to coerce anybody into going into clinical trial. We want them well informed. So the reason for not participating can be extra visits. Now, those, if you have to park, someplace that charges you $10, $20 to park, that can add up because of the trial. You have to go, first few days to get blood drawn or do this and that, physical exam, eye exam. So that can be one reason not to participate, because not only it's very time consuming, but it's also costly. The second reason would be the side effects. So some of the treatments can cause side effects that are not occurring with chemotherapy. It's not nausea, vomiting, diarrhea. It is immune reactions, causing liver damage or colon damage or lung damage. So that may be another reason you want to consider, like, think twice before you participate.
And is it true that if we decide to enroll in a clinical trial, it'll delay our treatment because it takes time for us to enroll into the trial?
Yes, and unfortunately, there is no regulation against that.
Mhm.
So what happens in clinical trial, there is a screening process. So if you are eligible, then you will sign a consent saying, it's okay to test my tumor for this particular uh, drug, like I look for a target on my tumor, so you can use this drug. Well, it's not going to happen just like that. So you sign the consent to give permission for screening, and that can take another week. So yes, there can be delays because you are trying to get on a trial. There are always alternatives. So please discuss that with the doctor. Like I mentioned before, you should not be put in a corner and say there is no other treatment. There has to be another option.
And I know placebo is standard of care, right? So chemotherapy, whatever standard of care you would be prescribing for a specific patient. But does being enrolled in a clinical trial and participating in a clinical trial, does that limit any future treatment options for patients?
No, it does not. I think this is a very good question. So, for example, in gastric and esophageal cancers, when the cancer is metastatic, like stage 4, there are 3 or 4 standard of care options.
Mhm.
So if you participate in a clinical trial in the beginning of the treatment journey or in the middle, you don't lose those standard of care options. We just sequence them. So if you don't take the third line treatment, but go on a clinical trial, you haven't lost third line treatment. It's still there for you.
Okay, that's good to know. Thank you. Can you talk a little bit about the recently approved biomarkers, the Claudin 18.2, and why those with HER2 positive are excluded?
Yeah, so the Claudin 18.2 is totally a new target, new biomarker in the entire oncology space, and it entered through trials in gastric and gastroesophageal cancer patients. So this can be found by immunohistochemistry, similar to HER2. You take a section of the tumor, put some stains, and you can see a biomarker for that stain. Now, why HER2 negative tumor patients were included and HER2 positive tumor patients were excluded from those trials? Because there is this good treatment from previous trials for HER2 positive tumor patients. That's why we didn't want to put them on this new treatment, which we didn't know whether it's going to be good or not. Now we know it's good, but that's the reason it is now prescribed or will be prescribed to HER2 negative tumor patients.
I have a few more questions that people from our stomach cancer support group had asked prior to this session, and we have a few more in the chat as well. With stomach cancer, diffuse gastric, CDH1 positive, I'm assuming, and HER2 negative PDL, and typically HER2 negative PDL1 negative, is it worth testing again to see if there are any biomarker and protein changes?
Yeah, so in such patient where the PDL1 is negative, HER2 is negative, I will check for microsatellite, and now I will check for Claudine. And there may be, emergence of repeat testing as we discussed before.
Okay. And then going back to Claudin 18.2 and, excluding individuals with HER2 positive, do you think that will change?
It's not likely to change in the near future because we have no understanding of how effective Claudine targeting is in HER2 positive patients.
Okay.
So, it will take some time.
So we have a patient who has a high expression of HER2 positive, HER2 amplification. She's on trastuzumab, and the only other significant biomarkers they have are VEGF-A, BRCA2, and Claudin 18.2. And we already talked a little bit about why HER2 positive patients are excluded from this treatment. Is there a targeted therapy for either BRCA2 or VEGF-A for this patient?
If the BRCA is germline, like they are born with BRCA mutation, yes, there is, but it's not approved. It's called olaparib,
Okay.
a PARP inhibitor. So Claudine, is a very interesting molecule or a target because there are now so many programs against Claudine. So zolbetuximab is not going to be the only drug. There
Yeah.
are ADCs out there that's very encouraging results. So you could also use those in HER2 positive tumor patients, but
Okay.
not in the beginning. But say, for example, HER2 positive tumor patient, you've already used first line treatment, second line, then you can go after Claudine ADC.
I see. Can you do Zolbe and immunotherapy at the same time, or do you have to pick the biomarker to treat, like each biomarker to treat?
No, Zolbe and immunotherapy has already been studied
Right.
and it is showing promising results, yes.
Okay. And then we have another patient whose past IHC tests indicated HER2 negative, except one liquid biopsy that showed that they have ERBB2 mutation with only 1% expression. They're currently on trastuzumab, and they've been on it since May this year. Should they drop trastuzumab? How effective can it be since they only have 1% expression, not the amplification? And will they be disqualified from Zolbe if they have the 1% of ERBB2 mutation? Sorry, those were like 4 questions in one, so I can break
Yeah,
them down. You
that's
too.
all right. So, we didn't pay attention to mutations like a
Mhm.
B2 mutation, but 3% of patients can have that. And HER2 targeting is very important in that group. So I would say don't stop trastuzumab, especially if there is no increase in the cancer, just
Mhm.
continue. And you
Mhm.
can ask your doctor to check the PD-L1. If it is high, then add pembrolizumab. For example, in lung cancers, her RB2 mutation also occurs at a low frequency, but drug like TDXD or Enhertu is very effective there. So
Mhm.
it makes HER2 a target if you have a mutation.
Okay, thank you for that. Any other questions from our group? And any tips that you have for talking with your doctor about treatment options? For me personally, I would go into every appointment with a list of questions, and I would ask my doctor every single question I had. My original biopsy report before my surgery, before anything, the biopsy from my original endoscopy showed that I had the PDL1 marker, and I learned everything about immunotherapy at that point and went in right away asking questions about immunotherapy. Do I get immunotherapy first? Do I get it after treatment or after surgery? Do I get it with chemo? So I did go in with a list of questions for every appointment. And I've finished immunotherapy in December of 2023, and I still go in with a list of questions every 3 months that I see my doctor.
Fantastic. I think everybody should try to do that because you want to have plenty of knowledge as about what's going on with the research, what's going on with your cancer, and what therapeutics, what other drugs are available. So I think it's a very good example.
Yeah, and something that I think, we don't often discuss when it comes to gastric cancer because it does disproportionately impact older individuals is for younger people who are getting diagnosed, and we do see more and more cases of younger adults who are getting diagnosed with gastric cancer. Ask about your fertility options too, because you do have those options. So ask about that before you start treatment and before you have to get on any of these medications because you are able to move forward with fertility preservation. So that's something to keep in mind as well.
Absolutely. Unfortunately, younger individuals are coming down with all types of cancer, but also gastric cancer. And, in older individuals, gastric cancer is a disease of men, like
Mhm.
66% will be men and rest are female. In younger patients, it's predominantly females. So this
Interesting.
is striking and very concerning. Yeah.
Interesting. Yeah, I was 31 when I was diagnosed, and then through my advocacy work, found out that many, many younger individuals are getting diagnosed with this and people younger than me. We have a question here. What do you think is the cause of this trend of younger people getting gastric and or esophageal cancers?
So this is something we don't really know. There's a lot of research going on, including at my institution, we have a big program. We don't really know. So it's pollution, is hyper processed food. It's probably a little bit of obesity, sedentary lifestyle, and all these chemicals that we eat or drink from water and foods that probably modify our hormonal systems. So there are a lot of speculations, but we don't have a good understanding.
I think cancer rates in general are rising, right, across all age groups. So I think we just have a lot more environmental exposures now to developing cancer, unfortunately.
Yeah.
I think we can move on, Dr. Ajani.
Okay, sure.
Thank you, everyone.
Okay, so we will talk about management of side effects, but here's a question you can.
Yeah. Quick polling question. Which of the following side effects do you find most difficult to manage? Nausea or vomiting, fatigue, diarrhea, decrease in appetite, or hair loss? You can pick one. Just waiting for the poll responses.
Okay.
Okay. Fatigue seems to be the highest, followed
Hmm.
by nausea and vomiting, and then diarrhea. We don't have any votes for decrease in appetite or hair loss. So can you talk a little bit about that, about the fatigue? Because I actually also selected fatigue.
Yeah, so all of these are very unpleasant, and more active you are physically, if you can become a little more active, you will kind of perceive these in a less severe manner. So that is one way to reduce side effects in general, not hair loss, but other side effects. So let's go through these, and I'll definitely address fatigue. So here's fatigue first. And it's very common with immunotherapy, with targeted therapy, of course, with chemotherapy. So what is recommended is to remain active. You can rest for a short time, like 15 to 20 minutes, 30 minutes at the most, but then get on your feet and do some things, especially when the sun is up, you want to be up and around. Um, and of course, more you're able to do today, less fatigue you will have tomorrow, and then it will be even less the day after if you do a little bit more tomorrow than you do today. So another thing is to get sleep at night, particularly, because if you sleep during the day, then you'll be up at night and you'll be tired all day. There are medications, some supportive group or supportive care clinics use, but they are not long-term solution. I think you have to kind of motivate yourself. The other one is diarrhea. And of course, the first thing is to exclude infectious reason for the diarrhea. But then there are many ways to deal with it, including medication, hydration, types of food to avoid, and type of food to have. And I hope these slides will be available to all participants. Nausea, vomiting also very, very difficult. And now we have guidelines by an entity like NCCN. So you can actually go there because they also have patient document for management of nausea, vomiting. And they provide you a lot of guides. And as we mentioned before about the cancer treatment, you can also become an expert in side effect management. So there's a lot written out there. Um, you can try many of these things, which can reduce. And there are some new drugs. There are patches, and there are some psychotropic drugs that can be very helpful. So hair loss is not such a big problem with HER2-directed therapy, fortunately. There is some hair loss, but a lot of times my patients tell me that only they know that some hairs are coming out, but the family or their friends don't really know. So this is not like breast cancer treatment where it's a bigger problem. And loss of appetite is very common with chemotherapy, targeted drugs, immunotherapy. And I think, one thing to consider is to ask for medication that can improve your appetite. And activity level, we cannot emphasize enough. More active you are, less of everything you will experience. And you should try that. Sometimes you have to force yourself to eat. Then there are a set of very serious side effects. Fortunately, we don't run into these often, but we have to keep them in mind. And there can be heart disease or lung disease for the second line treatment, low counts that can be adjusted. But most of all, if the patient becomes pregnant, then it's a very big issue, and we have to get a lot of consultations to figure out what to do. And this should not be decided by one doctor.
Thank you. So to our group here, to the audience, what questions do you have about managing side effects of treatment? And share your tips on managing side effects at home. Dr. Rajani, the previous slide with the serious side effects, what do we need to keep an eye out for when we're at home?
Yeah, I think anything that is, the physician's office will explain the common side effects to you.
Mhm.
I, if you are in a clinical trial, they will definitely talk about pregnancy
Of
and your
course.
partner, um, etc. Um, but I think anything unusual, out of uh, the context of what was explained to you, like you will have decrease in sense of smell, decrease in taste, but you get something, start bleeding or other ones that we listed. Heart problems, for example. Well, that needs to be taken care of by multiple disciplines,
Mhm.
and the treatment has to be stopped right away.
Right. But are there any specific side effects that are telltale signs for us at home when we start seeing some of these? It could be a potentially life-threatening or serious side effect, but we don't really know. And this
Yes.
is not very serious, but when I was going through chemo, I had clots. I had blood clots, and I didn't realize for a long time until I woke up one day with like my entire arm swollen because of the
Yeah.
blood.
Yes. So I think, always look out for anything unusual. So, for example, for HER2 particularly, that's what we're talking about today. You can get heart failure,
Mhm.
but the doctors are supposed to be checking your heart every 3 to 6 months. With the second line treatment, you can get what is called interstitial lung fibrosis or ILD. And that's a very serious side effect where you start to get shortness of breath and low oxygenation and cough. That has to be brought to doctor's attention immediately because not only we need to stop the drug, but it has to be managed very actively.
Mhm. We have a question actually, not about managing side effects, but kind of going back to biomarker testing. How often would you think a patient who is radiographically and clinically stable should have a diagnostic laparoscopy or an endoscopy ultrasound to get tissue for new biomarker testing?
Yeah, so this is an ongoing issue. If you have done the whole panel of biomarkers, currently all guidelines ask you not to repeat or
Mm.
no need to repeat. But every time I get a new tissue, for whatever reason, like a surgical intervention or endoscopic intervention, I I get the whenever I get new tissue, I will do additional biomarkers and NGS. So I think more tissue that is available should be studied carefully.
And can you talk a little bit about other types of side effects that we have from treatments? Of course, and I'm not sure if this is the right platform for this question, but we have all these physical side effects from treatment, but then what about managing and coping with like emotional stress?
So that is new to oncologists, you know. There was a suggestion not too long ago that all newly diagnosed patients and
Mhm.
perhaps some of the family members should have an encounter with, you know, a psychology team to be able to cope with this because the initial brunt of cancer diagnosis is just devastating. I don't think the infrastructures are robust enough to do that, but the need is definitely there.
Yeah, I don't think that's standardized across treatment centers, and that's unfortunate because I think it would be very helpful. We don't have many other questions for, managing side effects, but what about other side effects like neuropathy? Is that a side effect for HER2 positive treatment?
Yes, that is from oxaliplatin, and of course, that has to be carefully monitored and the drug has to be discontinued. I think most oncologists are very familiar with that.
Yeah. Yeah, and you do have other options, right? Alternative treatments as well for neuropathy, like acupuncture, for example, to help manage that.
Absolutely.
In regarding tips for managing side effects at home, do you have any other tips besides, what you had discussed?
I think again, education and having home medications and doing a little bit of research. If the patient is not feeling well, maybe ask a friend or caregiver to do some research and continue to ask questions. The good thing now is that we have this electronic medical record system where you can communicate. It's easier to communicate with the care team. So
Mhm.
you can just send a message as soon as you have that question in your mind.
Yeah, and it's a good segue to the slide, ensuring that I receive the care I need, because I definitely do use that platform a lot with my doctors. For the patients here, you want to always be sure to ask your healthcare team any questions you have. So, like I said earlier, I do go in with a list of questions about my treatment options, clinical trials that I could be eligible for, side effects, and how often I need to come in for routine office visits, but also my routine scans. Do I do these scans every 3 months versus 6 months versus yearly? And definitely ask who you need to call if you have questions or experiencing side effects. And I say this because some of us who are going to larger medical centers, you don't always have a direct line. So you want to have one contact number that you can reach out to if you have any questions. So make sure you have that. There are a lot of questions that come up, right, when you're insuring. Sorry, Dr. Johnny, can we go back?
Sorry, no, good.
No, no worries.
I think the prime group can go back. I cannot go back.
There
Maybe
are a
so.
lot of questions that come up, right, when you're ensuring that you receive the care that you actually need. And like we have said several times, getting this diagnosis is quite overwhelming. And I think you really need to go through and ask some of these questions that are listed here. What do these test results mean? How will this affect my quality of life? What does this mean for recurrence, right? If you're a little early stages, talk about recurrence and what this means for your quality of life after treatment as well. Um, what does this mean during treatment regarding your quality of life? Will you still be able to work? Do you have to manage childcare? What do you need to do to get help for childcare and other aspects of your life? Are there any clinical trials I should consider? You can find clinical trial information on clinicaltrials.gov. But you can also always ask your doctors for clinical trials that you may be eligible for. What are possible side effects and complications of these? What do I need to look out for when I'm at home without, being monitored by doctors and nurses? How can I make sure that I prevent these side effects and complications? And are there any treatment options that are less toxic? We do know the platinums are, quite we don't feel that great on them. Are there any
treatment options that are just as effective but less toxic. What about your financial ability to pay them? Is your insurance covering all these treatments? Will you have to cover part of the treatment, like administration of treatment? Your insurance could be covering the medication, maybe not the administration. So it's a lot of questions that you have to think about when you're first diagnosed, but it's really great to ask, your doctor's office for resources, for help. Ask them who you need to talk to in billing if you are worried about the finances, and ask to speak with a patient advocate or a social worker. They will get you in touch with one of the groups that they're working with or a social worker that they have on staff, and that would be very helpful. Thank you.
Okay. So I think we covered shared decision making, which means the patient, family, and caregivers are quite involved in what type of treatment is being planned. And there are multiple facets in terms of patient psyche, their religious beliefs or spiritual beliefs. Cost, as Mahati mentioned, very, very important. All that needs to be kind of understood before you jump into all this. And the thing that I don't see listed here is the commitment, your commitment. So your treatment team will commit to, doing this and that, like making a phone call to you in a week. But you also need to be committed to getting the treatment and complying with some of the requirements that will reduce toxicity to you. And the supportive care services are available in large institutions. You should ask for that. So nutritionists are there, social workers are there, care managers, case managers, and sometimes you get financial support. And as Mahati mentioned before, like yoga or acupuncture or music therapy, all of these are becoming more and more available. So the additional tip is, as we mentioned, you gotta hopefully you have a social support from your family and friends. That helps a lot because you cannot digest everything that is being explained to you. And then electronic medical record, of course, is very, very important. But now we have this device called Novelia, and that I found very fascinating because it can preserve the medical record for a long time from different vendors.
Okay, so we're coming up at time. So just really quickly, what questions do you have about supportive care or communicating with providers? And share your tips on how to advocate for yourself. What resources have you found helpful to support your journey? We have a couple questions in the chat already, Dr. Ajani. How does a person without a caregiver manage all these treatments?
Very difficult. I don't know how they do it, but I have some patients who are living alone, and we try to help them through social workers or case managers. But it is difficult.
It is. How does a person know if they should be looking for a trial if they are or are not doing well, if they're stable versus standard of care?
Yeah, I think this is a good question and should be asked. You should ask your provider whether is there a clinical trial available for me. So at my institution, there are hundreds of them, and we can match you with your medical history.
Okay. We'll take more questions and tips in the chat and we can come back to it. But right now I want to move on just because we're coming up at time. We have a member of the Novelia team. They're going to share some information with us on their tool and how it can help patients consolidate their health information for better outcomes. So I will hand it over to them.
Yeah, thanks, Mahathi. Thanks for moderating, and thank you very much for sharing your journey. It's really impactful, so thank you. And Dr. Ajani, really interesting presentation, so appreciate your time here. So hi, everybody. I'm Josh Salas. I'm an account manager at Novelia, and I'm here today to introduce you to Novelia, which is a platform that bridges the gap between patients and life-saving treatments by unlocking the power of your comprehensive and longitudinal health data. Now, we understand that sharing your health information is a really personal decision, and that's why we've worked hard as a company to earn the trust of different patient advocacy leaders across the country. And everything we do at Novelia starts with us asking the question, what's best for the patient? You can stay on this slide. So I'm going to walk you through, a heartbreaking and an all too common scenario. So here, Anna is a 43-year-old mother of two, and she was just diagnosed with gastric cancer. Like many people, she's seen a lot of doctors in various locations, which means that her medical records are scattered throughout different health systems and different charts. And when you're facing cancer, it's just getting all of those medical records in one place can feel insurmountable. And I know it's a lot to handle on your own. I saw the struggle firsthand when my mom was diagnosed with non-Hodgkin's lymphoma. Just the amount of data and information she had was a lot for her. And I wish that she had had access to a platform like this to help her manage her data. Next slide, please. So the good news in this situation is that I think more and more oncologists are helping their patients tackle the challenge of understanding their data. So they see firsthand how overwhelming it can be to keep track of all of their health data, like Dr. Ajani alluded to. And in this scenario, we can take Anna, for example. If she mentioned to her oncologist how frustrated she was trying to piece together all of her records from these different hospitals and specialists. In this case, her oncologist knew what to recommend, and they told her about Novelia, which is an all-in-one personal health tool that brings all of your records together in one secure place. A good part about this is that it's free, and getting started is really simple. You can sign up in just a minute or two. Next slide. So what does Novelia actually do for Anna? So rather than navigating through multiple patient portals and trying to piece together her medical history, Anna now has a complete view of her health journey in one secure place. So this includes all of her doctor's visits, lab results from different facilities, her full medical history, basically, and importantly, her physician's notes from each appointment as well. So Novelia presents all of this information on a dashboard that's comprehensive and easy to understand. So everything you might need during your health journey is just there. Is there with just a click. Whether you're preparing for an upcoming appointment with your oncologist or discussing your medical history with a new specialist. Next slide, please. So one of the most meaningful changes, for Anna is basically saying goodbye to the complexity of managing multiple patient portals. Before Novelia, she would have to keep track of different passwords or navigate through various interfaces, or sometimes have to bring paper records to her oncologist visits just to maintain her health history. And now there's an easier way. So Novelia really brings together everything into one secure platform. And it's very important to know that we've made security a top priority, and we ensure that her information and any health information on our platform remains private and protected. Next slide, please. So as I mentioned before, we fully understand that sharing your health data is a deeply personal decision. And that's why we're proud that we've earned the trust of some leading patient advocacy groups and healthcare providers who have recognized our commitment to protecting patient information. So here we have some pretty positive positive testimonials from both patients and physicians who have benefited from Novelia and from our healthcare physician partners who might have used it. And for example, many of our physician partners have actually been able to uncover real-world treatment insights that have improved the care that they provide for their patients. And we count that as a big win. We also have the pleasure of partnering with a handful of patient advocacy groups, which allows us to help patients like yourselves organize their complex healthcare data. Next slide, please. So at this time, I'd love to invite all of you to try Novelia for free. It takes a minute to sign up, and it really could help track what matters in your healthcare journey. So feel free to either scan this QR code to go through the registration process, or go to novelia.com/register/STP to join the other patients who are benefiting from the platform. And just a quick recap, Novelia brings all of your healthcare records together in one secure location, making it easy to stay on top of your healthcare journey. It can also help you track your medications and your symptoms so you don't have to remember 1,000 things. And we're continuously enhancing Novelia to better serve the patient. And we're doing this by adding various features like appointment preparation tools and symptom tracking features, which can make navigating the healthcare journey easier. And I also want to let you know that the Novelia team is here to support you. So if you ever have any questions or need help with anything within Novelia, just reach out and someone from our team would be happy to walk you through any issue you have or whatever you need. Again, thank you all very much for your time and listening to me and to the entire presentation, and happy to answer any questions that you might have.
Great, thank you, Josh. We have a question for you. Does it keep CT images, CAT scans, etc.? Imaging results?
Yeah, so that's a great question. At this time, it keeps the findings through some of those physician notes. It doesn't at this time hold the actual images in the platform. That's something that we are working on. But you can store kind of the outcomes or the findings from images within the platform right now.
Can you talk a little bit about privacy and
Yes.
data?
Yes, definitely. So privacy is very important to us, obviously. And whenever someone registers for Novelia, we go through fully HIPAA compliant data storage, which basically makes all of your data fully private. We can't share any of your personal information with any other organization. And I think the benefit of the platform is that while none of your personal information will be shared, the de-identified or aggregate findings from the patients on the platform have been used by researchers to understand the real-world outcomes of patients, which often differ from the results that are found in clinical trials. And it just gives these physicians a better real-world understanding of how their patients are reacting to treatments, et cetera. And like I mentioned, we partner with a health center, and they actually realized that their physicians weren't executing biomarkers for HER2 positive cancer as frequently as they thought, which was resulting in many patients actually not being put on the right therapies for a first-line therapy rather. So by educating the physicians on this de-identified aggregate data, we were actually to make a real impact at this institution where they now have changed their kind of biomarker protocol.
And it's free right now, right? How long is it going to be free, or is there going to be a payment plan or anything in the works for that, or is it free, period?
No, Novelia is free now, and it will be free, I believe, forever. The important thing for us is, most of the people who work at Novelia have had close family members who have suffered from cancer, and having cancer is such a burden in itself. This tool is meant to be free for anybody who could get a benefit from it. So free, you will never have to pay for it.
Excellent, thank you. And last question, does it share PHI with any research centers or hospital centers?
No, so we
Or just
don't
on-
share. No, we don't share any PHI or identifiable information with anybody. Again, we keep your privacy at the top of our mind, and that what we do share is strictly aggregate data that cannot be tied back to you in any way. And it just gives research institutions a much better understanding of how treatments are actually impacting patients in the real world.
Great, thank you so much for this information, and we'll share this information with everyone else as well. Any other questions for Josh, myself, Dr. Ajani? If not, then please take a few moments to complete the post-education survey. To receive your $10 Amazon gift card for attending today's webinar, you must submit this post survey and enter an email address on the last page. I just want to thank the Prime team, Novelia, Dr. Ajani, and supporters such as AstraZeneca and Daiichi Sankyo for offering us this opportunity to learn together. This concludes the program. Thank you everyone for who attended.